Good morning, good afternoon, good evening, friends, wherever you are in the world listening to us. I'm Sheila Maitra, Professor of Intensive Care, working at the Tata Memorial Hospital in Mumbai, India. I'm also the President of the Indian Society of Critical Care Medicine. It is indeed a very proud moment for me as I speak to you on behalf of my colleagues from the Indian Society of Critical Care Medicine and welcome you to this first joint webinar between ISCCM and the Society of Critical Care Medicine. This has been possible only because of the huge efforts of the president of SCCM, Dr. Vinay Nadkarni. We have been in discussion over the last few months about how we could improve the collaboration between SCCM and ISCCM. We have a long history going back, and you can see Professor Dr. Mission Levy, who's here, and he was the first president of SCCM who first signed an MOU, a Memorandum of Understanding between the ISCCM and the SCCM. And of course, subsequent presidents have taken this forward. And we are here today with the first webinar, joint webinar, and I'm sure there'll be many more. So on behalf of ISCCM, I welcome all of you. The theme of this webinar is on sepsis. It's prevent, treat, defeat sepsis. And who better can we have than the superstars of sepsis from the SCCM and the ISCCM speaking to us, and followed by talks. And then we have a nice interactive webinar. So once again, welcome and thank you for joining. And I hand over to my co-chair, Dr. Vinay Nadkarni, President, SCCM.
Well, thank you, Sheila. It's really a pleasure to be here. Good morning, good afternoon, and good evening. It really is sort of a launch of increased collaboration between the Indian Society of Critical Care Medicine and SCCM in the USA. And we are, as you said, really privileged to have the superstars of sepsis here with us today. The purpose of this is not to be sort of a lecture format, but it's really to be more of a discussion and an interactive counterplay of where we are now, what's working, what's not, and sort of where we're going in the future with surviving sepsis. We're going to be kicking off with a 12-minute sort of presentation by Mitchell, and then Dr. Devacha and Dr. Evans will be following that. And in the spirit of keeping this informal and interactive, I really would like us they'll kick off with their own introductions and then move along. The format will be these 3 12-minute sequential presentations, and then we'll have a little bit of just sort of 10 minutes of summary and interaction amongst the panel. But then the majority of this, the next 40 minutes, will be opened up for some specific questions for the panel and fielding questions from all of you who are participants. Because of the large number of participants, we're going to ask you to type your questions or comments into the chat, and Sheila and I will try to monitor that. And during that initial 10 minutes after the presentations, we'll present some of the key themed questions to those panelists for them to respond to. We also will have a few more folks who are experts joining us for the panel discussion, the 40 minutes. And so we'll have Craig Coopersmith, and we'll also have Suchitra Ranjit. And who else will we have? I think Subhash will be staying with us as well, right?
Subhash Todi,
so, without further ado, Sheila, let's move forward. And Mitchell, if you'll just give a very brief intro and move into the presentations.
Over to you.
Great. Thank you. It's such a pleasure to be here. Can you see my screen, hopefully? Great. So it's really an honor to be here at this first collaborative webinar between ISCCM and SCCM. And it's also, I want to thank Professors Nadkarni and Maitra for the kind invitation to be here. I've said this so many times when I've been in India, but I consider India to be a second home for me. And so it's really a pleasure to do this kickoff meeting. I am currently the chief of the Division of Pulmonary Critical Care and Sleep Medicine at Brown University. And it's former president of the Society of Critical Care Medicine, and was, as Sheila just mentioned, one of the first presidents to sign a memorandum of understanding between the ISCCM and SCCM. So what I'd like to do for about 12 minutes is talk about what's new in the 2021 campaign guidelines and are they working? I have this is my disclosure. I have some NIH funding and I'm on the advisory board for a couple of industry companies. This is a long history that I won't spend much time on, but it takes you up to date from the beginning of the phase 1 Barcelona Declaration of the Surviving Sepsis Campaign to the current time where we just received a study funding from the NIH in the United States to do a randomized controlled trial comparing the hour 1 bundle to the 3-hour bundle. You all know that this is phase 2 of the Surviving Sepsis Campaign. In particular, what I'm going to address today is the 2021 guidelines. What do I think was different about the 2021 guidelines? I think there are a couple of things that are important to note. There was clearly greater emphasis on panel diversity in terms of gender, geography, and economic. The questions were selected following, and I'll show you this slide in a moment, an international evaluation of practice and uncertainties. And finally, the PICO questions about long-term outcomes after sepsis were included for the first time in the 2021 guidelines. So this is the panel composition of the 2021 guidelines. And, you know, we're moving in the right direction, but we're certainly not there yet. You can see here, there's still an imbalance between the male participants and the female participants, and we're working towards improving that. You see a better geographic distribution, but still a predominance of North America. And I think we're going to talk a little bit about guidelines for lower and middle income countries over the course of this webinar. This is probably the best slide that addresses what's working and what's not working. And this is what I alluded to earlier, which was sent to 114 people over the globe internationally. And it basically says, what do you use most frequently? And what I think the most revealing thing, and these are all aspects of the guidelines on the left, and this is the most popular answer. But look at the distribution. We were able to get to 54% consistency as the second line agent after norepinephrine, which is vasopressin. But look at all the rest. Only 45% of the respondents, that's less than 400 people, use 30 cc's per kilogram. Only 38% use SIRS to identify patients who are infected. And the list goes on. So this is very important. And honestly, I think this reveals the fact that there's wide global variation in how we practice critical care. And yes, we like to believe in the Surviving Sepsis Campaign that the guidelines establish the gold standard for the metric, but as we're going to probably talk about later, some of these guidelines are not really available. Normal saline, for instance, and other things. So in resource-limited environments, even if we make the recommendation, it may not always be possible, let alone the controversy about some of these elements. So let me move on and talk about what I think is new in the 2021 guidelines in terms of recommendations. This is an important one because we actually recommended against the use of QSOFA compared with SIRS, NEWS, and MUSE as a single screening tool for septic shock. And you all know that QSOFA was introduced when we redefined sepsis in the Journal of JAMA in 2016. And since that time, there have been multiple published articles that demonstrate the inadequacy of using QSOFA for routine screening for sepsis. And this, in many ways, I chose this manuscript because it really shows the difference in many ways. We originally proposed QSOFA as a way to predict who would deteriorate. And instead, what is being more commonly used is screening for sepsis. And so remember that the QSOFA score was developed by the folks by the panel in general for 2016, but by the folks at the University of Pittsburgh that was based on a database in which these patients were considered already infected. And so you can see that, yes, the point estimate is statistically significant in favor of predicting mortality, but in fact, when you look at sepsis and predicting the existence of sepsis, QSOFA performs very poorly, which is exactly why we recommended against the routine use of QSOFA for scoring systems for identifying sepsis. What about liberal versus restrictive fluid strategies? Well, the panel's recommendation was that there is insufficient evidence to make a recommendation on the use of restrictive versus liberal fluid strategies, despite the fact that we did make a suggestion to continue with 30 cc's per kilogram of fluids initially for resuscitation. And I think the most important piece to show you is the Clovers trial, which was published in the New England Journal this past year. Basically, this was an RCT by the PEDAL network, which is the former ARDSnet network. It was targeted initially for 2,320 patients. It was stopped for futility at the second interim analysis after only 1,563 patients. And the enrollment criteria were septic patients with refractory hypotension after 2 liters of fluid resuscitation. And I want you to notice that this is after 2 liters. So in many ways, and this is true for all of the early goal-directed therapy, that the standard of care seems to have been and is 30 cc's per kilogram, which is about 2 liters in a 70-kilogram person. So even in Clovers, after they're hypotensive and they get 2 liters, then they're enrolled. This is the difference between the 2 protocols, and I don't really have the time to go through each, but you can get up to 1 to 3 liters even in the restrictive group, and you start with 2 liters and you continue after that. The primary outcome was all-cause mortality, and you see the secondary outcomes on the slide. You see the difference here, and there was a significant difference. Over a 6-hour period, the restrictive group got only 500 cc's, whereas the liberal fluid group got 2,300. And you see over 24 hours, it was 1,300 versus about 3.5 liters. More importantly, and what I want to point out is these next 2 boxes, that this is really not just a trial of restrictive fluid, but it's also early vasopressors. And you can see here almost a full day earlier the use of vasopressors in the restrictive group. What I would say, the conclusions of the trial is this was obviously a negative trial. In this trial with sepsis-induced hypotension, refractory to 1 to 3 liters of IV fluid, the restrictive strategy didn't result in a significantly lower or higher mortality before discharge. And I'm sure we'll talk about that more over time. The next thing I wanted to highlight is the recommendation against the use of vitamin C. And there are so many trials, well done, randomized controlled trials. This one's from the New England Journal, published in the last year or so. There was the Victus trial that I believe was published in JAMA, also from the United States. So this one's from the Canadian critical care trials. And this is the use of vitamin C in patients on vasopressors less than 24 hours in the unit. Again, the primary outcome was 28-day all-cause mortality. And you can see here that there was no difference in death or organ dysfunction at the end of 28 days. And this is more and more commonly a composite outcome is being chosen for large phase 3 trials. And so I won't say anything more about this other than to say that I think, based on all of the negative RCTs out there, that the era that we have finally put to rest this question about the use of vitamin C in sepsis, and the answer is don't use it, which is why we recommended it. again, I'll pass that over. So in summary, I would say that there are, well, in the 2021, and part of the issue, of course, is there were 93 total recommendations. There was a new recommendation on capillary refill time in favor of using capillary refill time based on a well-done RCT that was published from Europe. Empiric MRSA coverage, empiric fungal coverage. Now we know that it's safe for in the first 24 hours to use peripheral vasopressors. A recommendation against levosimendan, a recommendation in favor of high flow nasal cannula versus a non-invasive ventilation. For the first time, we made a suggestion of in favor of ECMO, again, a suggestion in patients who fail conventional mechanical ventilation with ARDS. And as I mentioned already, we, for the first time, made recommendations about the use of family. So the major take-home points: don't use QSOFA for screening. There was a continued suggestion to use 30 cc's, but not enough evidence to suggest for or against restrictive versus liberal. Immediate antibiotics for shock or if you suspect sepsis. And finally, inform the families about long-term outcomes. And with that, I'll say thank you, and it's a pleasure to be here.
Thank you very much, Professor Levy, for that excellent presentation. I'm sure there are going to be lots of questions. I now welcome Professor Devatia, who's from my institute, the Tata Memorial Hospital. He's also been the past president of ISCCM, and he's published the INDICAPS 1 and INDICAPS 2 study, which gives you data from India about Indian ICUs and what the sepsis scenario is in our country. He's going to be speaking to us about how we can manage sepsis in resource-limited settings and specific challenges. Over to you, Professor Devatia.
Yeah, good evening, and thank you very much for this great initiative. And I will be speaking on how we can manage in resource-limited settings. This is my disclosure. Now, what do we mean by a resource-limited setting? I mean, so, you've got infrastructure in the ICU, which may be limited. Then we limited options for monitoring, for choices of fluid, for choices of drugs and other sort of modalities of treatment. But also in a resource-limited area or resource-limited country, there might be diseases peculiar to the environment, and there might be socio-economic and cultural factors which make management maybe different or difficult, or, in some ways with different types of patients. Of course, there might be areas where there's limited knowledge and limited expertise, both in terms of the knowledge of guidelines, familiarity with procedures, facilities for transport, and so on. And very importantly, in many of resource-limited countries and poorer countries, antimicrobial resistance and prevalence of nosocomial infections are extremely important limiting factors that can make a difference to outcome. When we talk of resource limited, the two sort of studies which spring to mind are the FEAST study, which was done in sick children in South Africa, in Kenya, and this simpler goal-directed therapy protocol in Zambia. But I will not be really discussing these studies because these were extremely resource limited, very different patient population from what we see in general ICUs. Most of the times, or almost all of the times, they had no access to intensive care, mechanical ventilation, and so on. But instead, I will sort of try and stick to a more sort of conventional sepsis that we see in Indian ICUs. And a lot of the data I will be presenting will be based on this study, which is the INDICAPS, so the Indian Intensive Care Case Mix and Practice Pattern Study. And the second one, which we did in 2018 and 19, was a 4-day point prevalence study. And we had data from 132 Indian ICUs and almost 4,700 patients, adult patients. Okay. So in this study, the prevalence of sepsis and septic shock was about 29%, and the mortality in the ICU was close to 37%. If the patient had shock, which was presence of sepsis and vasopressor use, the mortality was exceeded 50%. So sepsis in Indian ICUs in the INDICAPS 2 study was associated with fairly high mortality, and shock was even worse. The organisms, both in INDICAPS 1, which was done in 2010 and 11, and INDICAPS 2, which was done in 2018-19, there was a predominance of gram-negative infections. Unlike in a lot of data that we see from the West, most of the infections are gram-negative. And in the 2010, the predominant infections were Pseudomonas and Acidobacter. Klebsiella and E. coli are lower down, but now we've got Klebsiella and E. coli overtaking these, and these are all multi-drug resistant and especially carbapenem resistant bugs, which have sort of crept in to the ICU. There is a smattering of fungi, but at least in this study, it was about to the extent of 7 to 8%. The tropical infections like malaria, dengue, leptospirosis, and streptyphus were there in about 10% of patients with sepsis. So they did not make up a huge burden of sepsis in the ICU. Maybe they were there on the wards, but just about 10% of septic patients with sepsis had these tropical infections. And these were confirmed by laboratory tests. So these were not suspected, these were confirmed by laboratory tests. And these patients tended to be much younger. They had a fairly severe organ dysfunction, and I suspect it's largely hematological and liver dysfunction. But they had lower Apache scores, partly because they were younger, but maybe the other organs were okay, and they had a significantly lower mortality. So our tropical infection patients tended to be younger, tended to be sick, but still seem to do much better than those with the other conventional bacterial types of sepsis. Okay, now coming to the treatment of patients with sepsis, and if we look at our one bundle, which has been recommended along the lines of the Surviving Sepsis campaign, there are 5 elements over there. And measurement of lactate seems to be a problem even in many of our ICUs. So, and we'll show you some data about that. So that may be a problem. Blood cultures, yes, but many ICUs actually outsource their microbiology labs, and therefore, while they're able to do microbiology in routine hours, they may not be able to collect blood cultures prior to antibiotics in an emergency or after hours. Broad spectrum antibiotics are given, and that's easily doable, but antibiotic resistance may limit what the appropriateness of the antibiotics that we give. Of course, we can give fluids, but again, like because of measurement of lactate may not happen, and most of the times the trigger for fluids would be hypotension, right? And of course, we can use norepinephrine for the treatment of hypotension. So we are able to do many of the elements, almost all of the elements, except maybe those which have something to do with lactate. Now, like I mentioned, antimicrobial resistance is a real problem as far as giving appropriate antimicrobial therapy. We can give broad spectrum antibiotics, but they may not be appropriate. And if you look at this data, which was again done from about 20 Indian ICUs, which was published in 2018, but the data was collected a year or two prior, again, you find Acinetobacter, Klebsiella, Pseudomonas, E. coli are the predominant organisms, but the resistance in the tracheobronchial aspirate, the resistance to the extent of 60 to 88%. So multi-drug resistant organisms. This was in 2018. And if you look at bacteremias, again, there is a predominance of gram-negative, the same gram-negative organisms, and the resistance is to the extent, multi-drug resistance to the extent of 36 to 64%. So a significant problem of antibiotic resistance. And this resistance, of course, it's there in the ICU, but I think it's part of a greater problem. There is very lax regulation, freely available antibiotics, very often over the counter in the community. Okay, and of course, there's because of crowding, resistant bugs can spread. And maybe even patients who recover from intensive care carry resistant bugs back to the community, and then they come back to the hospital. And again, in the hospital, there are issues of lack of infection control or antibiotic policies, a lot of empirical use, especially for surgical prophylaxis. So it's a problem which, of course, we have to handle in the ICU, but I think it needs a larger perspective or a larger canvas that needs to address this sort of thing. Now, when we talk of resuscitation from sepsis, now this is a typical sort of patient who would present to an Indian ICU with sepsis. So he would start off, let's say, with some symptoms. He would go to a general practitioner who would maybe give him an antibiotic. If he didn't respond well and he's remained unwell, then he would be admitted to what we call as nursing homes, which are actually small community hospitals, not the nursing home concepts that you have in the West. So these are small community hospitals, 10 to 30 or 40, 50 beds. And they would come here. And this is actually time when they actually reach something like a hospital. And maybe this would be time 0. It's very difficult to determine what would be time 0 in this sort of patient. but they would reach here. And this is the time they should be getting their early antibiotics and early fluids and recognition of sepsis in the first place, right? And then, but here maybe this doesn't happen to that same extent. And they get some antibiotics, but they get sicker. And then we are transferred to a referral center where they get the whole bundle, but maybe it's a bit too late. So I would suggest that this entire exercise of education and early intervention, of course, we should teach it to the intensive care and emergency departments in the big hospitals, but we need to target this to the smaller nursing homes or the community hospitals, because that's probably where time zero is occurring. And that is the sort of focus where we need to focus or refocus our efforts at education on early recognition, early antibiotics, and early fluid resuscitation and correction of blood pressure. So that's maybe one thing we need to work on in our country. Okay, now we all follow the Surviving Sepsis Campaign guidelines, and they suggest, that we should use initial dynamic measures over physical examination alone, and they suggest using lactate as a target for resuscitation and capillary refill. So there are some perspectives on this. So I think the clinical examination does give you a very good idea of tissue perfusion, and the three windows, the skin, the brain window, the skin window, and the kidney window. They all seem to give you some idea, and skin mottling is a good sign, but sometimes in dark-skinned patients, skin mottling may not be as apparent. And in a dark-skinned patient, the presence of mottling actually suggests a very advanced stage of fibroperfusion. And the capillary refill all seem to work reasonably well. We can use simple measures even from the mean arterial non-invasive pressure, like the pulse pressure has a correlation with stroke volume. And if the pulse pressure, which is initially low, increases with fluid administration, it suggests that, the stroke volume has increased. You can use a diastolic pressure as a trigger for vasopressor use, and you can also use the shock index, because that also gives you some. So you can get some indication by clinical examination and elements of the blood pressure. You could use a pulse oximeter plethysmographic waveform to see something like the pulse pressure variation, the variation in the plethysmographic, to give you some idea of fluid responsiveness. But at the end of the day, in many ICUs, you could still put an arterial line, which I think is extremely important. And, it's not expensive at all, and it's very cost effective. And just examining the arterial waveform will give you so much information about fluid responsiveness, the contractility of the heart, the stroke volume. The dicrotic notch position would tell you about something about the SVR. If it's low, the SVR is low. So you can have a very good idea by eyeballing the arterial waveform. And a very important information is the pulse pressure variation. And this is a useful parameter because it does not require cardiac output monitoring. Of course, it does require that the patient is mechanically ventilated with a tidal volume of 8 mils per kilo or higher. And in that situation, a pulse pressure variation of more than 13% suggests the patient is fluid responsive. And this is an extremely important semi-non-invasive way of sort of knowing what the fluid responsiveness of this patient. Of course, most patients in the ICU are ventilated with a low tidal volume, and the tidal volume challenge using the pulse pressure, by just increasing the tidal volume from 6 to 8 mils per kilo for a minute, and the change in pulse pressure variation when you increase the tidal volume from 6 to 8 ml per kilo with a cutoff of 3.5 is an excellent predictor of fluid responsiveness in patients with low tidal volume ventilation. So the tidal volume challenge is a very simple test, does not require cardiac output monitoring, does not require change in position, just tweak the knobs on the ventilator. And in a patient on low tidal volume ventilator, it sort of improves the performance of the PPV in detecting fluid responsiveness. Of course, the passive leg raising test has been described, and it's an excellent test, but it requires a real-time cardiac output assessment device, which is a limitation in resource-limited settings. You could use the pulse pressure variation or the pulse pressure, but it's not as accurate in that sort of setting. Now, the capillary refill time has made a comeback. It's something we've been using for years informally, but now there has been a formal sort of analysis or formal evaluation of the capillary refill time, and it seems to perform very well as an index of peripheral perfusion, even comparable to lactate. Although it's maybe the prognostic ability is not as good, but it responds much faster to fluid resuscitation or to resuscitation in general as compared to lactate. So the real-time response to resuscitation is much better captured by the capillary refill time, and the dynamics of recovery are much faster. And therefore, you can track the progress of resuscitation much better using the capillary refill time as compared to lactate. And of course, it's simple, readily available, costs nothing, and should be ideal for a resource-limited setting. And the Andromeda shock trial did show us that resuscitation targeted to the capillary refill time is as good, or maybe as lactate levels. So I think that's something which is very positive, and we look forward to Andromeda shock 2 when the results, so that study does get done. So this is just a summary of what were the sort of monitoring modalities that were done in INDICAPS 1 and 8 years later in INDICAPS 2. And you can see that arterial pressure monitoring is not very common. It has increased with INDICAPS 2, but still just in about less than 40% of patients with sepsis that we had invasive arterial pressure monitoring. The CVP line use actually dropped. Maybe it's a result, as well as the SCVO2 monitoring significantly reduced. Maybe it's a result of the trials that came out, Process, Arise, and Promise, and so on. Cardiac output monitoring is not common at all. Pulse pressure variation increased to about 9.4, but again, it's not very much. And lactate levels, like I said, in just about half the patients, they were monitored in 2018-19 in INDICAPS 2, but in the previous study, it was just about 22%. So lactate is something which is important as far as the pathophysiology of sepsis and septic shock are concerned, but there seems to be an issue with the availability and use of lactate. Finally, just coming a bit to fluids, it's a bit of a whammy for us that albumin is the preferred colloid if a colloid has to be given, because it's extremely expensive. And, of course, starches and gelatins now have a suggestion or recommendation not to be used. So this is a bit of a problem if we have to use a colloid, but so it's a cost issue. Okay. Lastly, coming to nosocomial infections, now this is a problem. So this is a study which was done so many years ago, but it does tell you what the problem is. So they looked at Indian ICUs, 21 Indian ICUs, and the incidence of ventilator-associated pneumonia was 17.4 per thousand ventilators. It's extremely high. The good news was that with an intervention, which was the INIC bundle and education and process surveillance and feedback, we were able to reduce it by 38% to 11 per thousand ventilators. And in our ICU, we've seen a steady reduction over the last 10, 15 years. And so it's extremely doable, but we do have to worry about nosocomial infections, and we have to work towards reducing our nosocomial infection rates. Finally, we must set goals of care, and end-of-life care decisions must be made where appropriate, because then it's, of course, it saves the patient the agony, it saves the patient money, it is much more efficient for the system. And so we need to discuss goals of life and end-of-life care in appropriate times. So thank you very much for listening, and be happy to take questions at the end.
Well, thank you, Dr. Devashia. That's really fantastic, and a lightning tour of the issues that are presented in India and in other resource-limited settings. We're already getting some questions about the reliability of cap refill in a cold environment, and some questions about the broadness of the spectrum of antibiotics that should be used in sepsis or severe sepsis or septic shock, whether there's differentiations there. So we'll address those at the end of the next presentation. We'll move right on to Laura Evans. And Laura, I know that you're the first author of the 2021 guidelines, surviving sepsis campaign guidelines, but just give a sort of a 30-second intro of who you are, and then we'll go on to your short presentation.
Thanks, Vinay, and hopefully you all can see my slides. And it's a real honor to be here. Like Vinay said, I'm Laura Evans. I'm a professor of pulmonary and critical care medicine at the University of Washington, and I've had the fortune to be involved with the Surviving Sepsis campaign since about 2010. Which was just happenstance, quite honestly. Sheila was talking earlier about, Mitchell and his impact with the Indian Society of Critical Care Medicine, and being the first person from SCCM to sign an MOU with ISCCM. And Mitchell was also very formative to my career. And so I ran into Mitchell merely by coincidence at a collaborative effort to reduce healthcare associated infections. We got to talking. He became a mentor to me, and that was basically my entree into the Surviving Sepsis campaign. So I'm really appreciative of that. I'm very appreciative of the opportunity to be here today with you and to be a part of this inaugural webinar. And particular acknowledgement to both Sheila and Vinay for the invitation to be here. I also do want to take the minute and just acknowledge that I was the previous co-chair of the Surviving Sepsis Campaign guidelines for the 2021 revision and with the 2016 revision, both with Andy Rhodes from ISCCM. I am not the co-chair of the upcoming revision, which is targeted to be published in 2025. That's the SCCM co-chair is Hallie Prescott from the University of Michigan, who was not able to be here today. So I do want to acknowledge Hallie and tell you as well that she and I collaborated on preparing these slides so that I accurately represent kind of what's coming up next with the Surviving Sepsis Campaign guidelines. I'm going to stay out of a lot of the kind of clinical weeds here. I noticed a lot of comments coming to the chat, which is fantastic. Please keep them coming and we'll do our best to kind of get into some of these clinical topics here, but I wanted to give you kind of a preview of what the guidelines might look like going forward. I don't have any financial conflicts of interest to report. I am a co-investigator on the NIH-funded study of the hour 1 and 3-hour bundles that Mitchell mentioned earlier. You also saw a variation on this slide earlier that just, I think it's really important to contextualize the Surviving Sepsis Campaign. It has now been more than a 20-year effort. Like I said, my involvement started kind of, when the Surviving Sepsis Campaign was already well established in 2010. But it continues now in 2023 and keeps going. We had our most recent guidelines published in 2021. Mitchell mentioned there's now a NIH-funded randomized controlled trial, and we're on target to kind of begin the next guideline revision process and with a target publication of 2025. And it does take still about 4 years to go through this entire guideline process. It's very robust, it's very rigorous, it does take a lot of time. We've had a lot of conversation over time within the Surviving Sepsis Campaign, within the Society of Critical Care Medicine, with the Society of Europe, the European Society of Intensive Care Medicine, about is there a way to make the guidelines process more nimble and make the guidelines sort of smaller, shorter, more user-friendly and able to be updated more frequently? And I'd be really interested in maybe getting into this in the chat as well, in terms of what are the benefits and drawbacks of that approach of more frequently changing guidelines. And is there a frequency at which guidelines would change too much and clinical personnel don't have the time to react? So this is the slide here that shows you the 2025 guidelines panel leadership. As I've mentioned, Hallie Prescott is the co-chair from the Society of Critical Care Medicine. Dr. Massimo Antonelli is the co-chair from ESICM. Bram Rockwork from Hamilton, Ontario is the SCCM vice chair. Lenny Durde is the vice chair from ESICM. Dr. Walid Al-Hazani is once again the lead methodologist representing the guide group at McMaster University. And myself and Joseph Kezdioglu are the conflict of interest co-chairs for the 2025 guidelines. And COI management is a really important part of producing a reliable and valid guideline. When we think about some of the priorities for the 2025 revision, I think you already heard a little bit from Mitchell about the evolution of the guidelines over time and trying to have a panel that better represents the global burden of sepsis. You also heard from Professor Devasya about this importance of recognizing and managing sepsis upstream before we get to the intensive care unit. That probably our best impact is actually well before a patient gets to the ICU. And when we translate this into priorities for a guideline revision, we're talking about having better emergency medicine representation in terms of that getting to the patients before they're so sick that they're in the intensive care unit. We're continuing to talk about improving representation from low and middle income countries. Obviously, we want to make sure that our questions are clinically relevant, that the guidelines have good methodologic rigor and provide actionable guidance whenever possible. Sometimes that's not possible, and we already heard about recommendations where we went through the entire process of asking the PICO question, doing the systematic literature review, summarizing the literature, and still said we can't offer a particular guidance on this. And that would be the example of fluid being more liberal or being more restrictive with fluid management after initial resuscitation. This is not news to anybody on this webinar from that, but I did want to just represent the data that Christina Rudd published in The Lancet in 2020 that just emphasizes that the sepsis has a massive global burden. I'm representing here the United States, where you can see on these graphs is lighter colored, which indicates less impact of sepsis compared certainly to most of sub-Saharan Africa. And you can see India there, which is as sort of a medium to dark blue, representing a higher burden of sepsis than in North America. And there's estimated to be almost 50 million cases annually in 2017 with 11 million deaths. So clearly a massive problem and estimated to contribute to almost 20% of all deaths. So to get to this, and I hope we'll have more discussion about this as well in our later section, is how do we incorporate low and middle income countries into a guideline development process? Traditionally, guidelines have really been representing data that originates from high income countries. And how much that can be extrapolated or applied in different resource settings is variable. And obviously not all low and middle income settings are the same either. We already heard very nicely represented that, India is very different than Brazil, which is very different than Zambia. So not necessarily, it's not an all or none phenomenon where every low and middle income country gets the same guidance. To try to get to this question and to be more useful to the end users, with the next guideline representatives, there's actually going to be a panelist, Dr. Luciana Azevedo from Brazil, who is the designated lead for low and middle income country panelists. The guidelines will have a minimum of 2 panelists from a low and middle income country in each work group, with the goal to offer advice on what to do in settings where the guidelines recommendation may not be feasible. Now, that advice may not have the same quality of evidence behind it because it's really extrapolations of data for the most part, but at least to offer practical guidance and tips when the guideline recommendations may not be applicable. The guidelines, again, will be developed into the same 6 work groups that they were last time: screening, initial management of sepsis, infection, hemodynamics, ventilation, additional management, and long-term outcomes. And we heard some conversation earlier about the importance of long-term outcomes and looking beyond just the metric of survival, but actually what happens to our patients after sepsis. Are they able to return to work? What long-term problems do they have, both financial, social, medical, and the impacts on families as well. The reason that the guidelines take a long time to do is because of this rigorous guideline development process. We use the grade process, which starts with an evaluation of the evidence. We mentioned that last time we did something new with the guidelines in 2021, which started with looking at variation in practice as a means to help us develop PICO questions to ask. If there's not a lot of variation in practice, across intensive care units, across regions of the world, maybe those questions have already been answered and they shouldn't be in the guideline. We're trying not to produce a guideline that is a textbook of all intensive care, but rather a guideline that answers particular questions where there's clinical uncertainty. So we'll go through this process. They'll select PICO questions, prioritize outcomes, do systematic reviews and meta-analysis when they don't exist, develop evidence profiles, grade the evidence, then put this through a formal evidence to decision framework where panelists have to weight each of these particular questions. Well, how important is the problem? What are the desirable and undesirable effects of the intervention? How certain are we in the level of the evidence, balance of effects, and so forth? And then use this formal framework to make recommendations, draft them, vote on them, discuss them as a panel, revise them, and revote as necessary. So you can see why it takes a long time. I always put this slide in my talks because I think it's a really important one, is that not all guideline recommendations are the same, right? They don't all come with the same level of evidence behind them and the same weighting to that. So once again, the guideline will include best practice statements, which are strong and ungraded recommendations. It will have strong and graded recommendations, which will be framed as we recommend. It will have weak graded recommendations, which will be framed as we suggest. Or potentially, again, no recommendations when we've gone through this whole process and are unable to issue a specific guidance. And the implications of these types of recommendations makes a big difference. When you look at the Surviving Sepsis Campaign guidelines, which, obviously I think we're extremely proud of, but we have 93 recommendations, of which 13 are strong recommendations. The majority of them are weak recommendations, which I also think serves as a call to action to us as members of professional societies, as clinicians taking care of patients, and as researchers to continue to investigate these questions, to continue to ask questions so that our evidence base improves. I'm going to steer cautiously into territory of what potential, and I bolded this deliberately because none of this has been decided, but potential areas for inclusion in the next guidelines or ongoing controversies, I think, continues to be the question of liberal versus restricted fluids. There's new evidence, obviously. I was so glad that Professor Devashia mentioned arterial line monitoring, because I think there is enormous practice variation both within regions and between regions on the frequency and use of arterial lines. And so looking at taking a systematic look at the evidence that supports or refutes the need for arterial line monitoring. Peripheral vasopressors, we mentioned this last time, but there's obviously more data on that, as well as around duration of the use of peripheral vasopressors, balanced fluids, fluid or cortisones come back again, the role of rapid pathogen detection, and much, much more. These are kind of things that just come to mind readily, but again, nothing has been set in stone with that. I wanted to, again, just thank you all for the opportunity to be here, and I'm looking very much forward to the chat.
Thank you so much, Professor Evans. That was an excellent presentation. I think all the three presentations have been excellent, and we have lots of questions for all three of you coming in the chat. If I may, I'd like to ask Professor Levy the first question coming from one of the delegates, attendees, who's asking that if, when we have a patient initially who presents with sepsis, suspected sepsis, septic shock, we usually tend to drown them, give them lots of fluids, and we also tend to start vasopressors early. Now, if we reach a point where the patient is not fluid responsive, we're already a high dose of vasopressors, and the patient is still hypotensive, what are our options? And can you also touch a bit on methylene blue and what is, the current role and going forward?
Yeah, those are great questions. I like that you use the term drown patients, because I think that's the perception of 30 cc's per kilogram, but in a 70 kilogram, and remember, we consider now using ideal body weight. So ideal body weight, which is about 3 liters, 2 or 3 liters, is not, to me, drowning someone. And yet, that is the perception, especially in end-stage renal disease and cardiomyopathy patients. So the first thing is, I start with fluids. For us, we use 30 cc's per kilogram ideal body weight, and then start vasopressors as soon as we need them. The question you ask of, and the problem is, there's ongoing capillary leak. So when you use dynamic measures of responsiveness, you start to continue to see patients be fluid responsive up 24, 48 hours. So how much fluid do you give them? And yet we know that the more positive the fluid balance leads to poor outcomes. So I tend to use, like the Clover's trial, higher doses of vasopressors. So I push norepinephrine to 40 micrograms per kilogram. I use vasopressin quickly, and sometimes I'll add a third pressor. So I tend to go to fluids earlier and somewhat limit the amount of fluids. How much do I limit it to? I don't know that I can make that up, because it would be totally arbitrary, but I try not to give more than about 60 cc's per kilogram. So I think what I'm saying is, yes, I do 30, I give some more fluid, and I use early vasopressors. And for methylene blue, we don't use much methylene blue. I do know that methylene blue for peripheral, for resistant hypotension is a good idea. So we haven't used much of it. We have one of our attendings is also ID boarded, and so he tends to turn to methylene blue more frequently than my pulmonary critical care faculty.
And Mitchell, you mentioned that on the survey for a second agent, there seemed to be a little enthusiasm for vasopressin. Is there information, was there enough data to make a preferred second agent? And there were in the chat some requests for some comments about levosimendan? Is it time to, to abandon that, or is it time to embrace that?
Yeah, so I'll defer to Laura about, I do know that the Europeans like epinephrine as the second line agent, and the Americans and North Americans in Canada tend to like vasopressin as the second line agent. I don't know that there are enough head-to-head randomized controlled trials to clearly establish the supremacy of vasopressin as a second line agent. So we use it as a second line agent routinely, but I don't know that there's enough of an evidence base. Laura, did you want to say something about that?
Sure, happy to weigh in, thanks. So in the 2021 guidelines, we did make a weak recommendation for vasopressin as a second line agent when norepinephrine is not sufficient. We actually did something that also, I think, representing this, again, this practice variability that exists both regionally, but obviously between countries and regions as well. There's lots of issues with availability of vasopressin in parts of the world. There's lots of issues with the cost of vasopressin as well. And so there's multiple factors, I think, that weigh into your choice of second vasopressor. When we looked just at the evidence, we said, there's probably enough there that we can issue a weak recommendation for vasopressin as a second agent from that. And then we asked the panelists, we did an actual survey of the panelists saying, what's your threshold? When do you add that second agent? At what dose of norepinephrine? Not getting into the different preparations of norepinephrine, but saying, based on when you look at the dose of that norepinephrine that your patient's on, kind of what's your range that you would think about adding a second agent? And this is called an in our practice statement. So it's not a graded recommendation. It's just the panel's opinion saying this is what we do. And the kind of average range that people started this was, we used weight normalized norepinephrine, was about 0.25 mics per kilo per minute of norepinephrine. Was people said that's basically when I start thinking about adding vasopressin. Is that the right answer? I don't think we know. We're just saying that's what we do right now.
I think we need more data, right, before we can make a recommendation. I want to ask Professor Devatia, excellent talk. You spoke about the issues with lactate availability. We still don't have lactates available across the board, not only in India, but in various resource limited settings. So the Andromeda shock study was, gave us some, hope about using capillary refill time. And now we have the Andromeda shock 2 study. So what are your thoughts on this? For centers that don't have lactate, should they be using capillary refill time? And what are the limitations with the use of capillary refill time? Your thoughts on this?
Okay, so that's a handful, but okay, so capillary refill time is good, okay, and the Andromeda shock study did show that it works. And so capillary refill time of more than 3 seconds suggests that your circulation or perfusion is not good, not great. The problem is one is reproducibility, and it depends how you do it. And the Andromeda shock in the trial, they are very, I'd say, complicated, because they used a slide and they used a stopwatch to see the blanching and see the refill, and they timed it and so on. And most of the time we just we press the finger there like this and we release it and we say, yeah, that's fine. So it does give, well, it gives you some eyeballing, may be useful, but if you want to really it's not as reproducible all the time. Secondly, even in the Andromeda shock study, a number of patients had a normal capillary refill time to start with, even though they had septic shock. Maybe they had they had a high volume, high cardiac output distributive shock, and the capillary refill time may not have been prolonged to start with. So in those patients, of course, you cannot use the capillary refill as your go-to test to test your peripheral perfusion. Thirdly, sometimes if there's a lot of cold, if there's the atmosphere is cold, the air conditioning is too cold, the fingers are out, maybe that might compromise on your capillary refill, but maybe you can take care of that in a while. But otherwise, capillary refill time seems to be good. Now, although we say Andromeda shock, I think Andromeda shock had a very complex protocol, which included all the elements of invasive monitoring and pulse pressure variation and testing for fluid responsiveness, including the tidal volume challenge and so on, and then using capillary refill to test for adequacy of perfusion. So I think we need to keep that in mind that, you need to still assess fluid responsiveness. You need to assess other parameters of the circulation and not just say, okay, I'll do the capillary refill time. And if it's prolonged, I'll give fluid. You might need inotropes. Patient may not be fluid responsive, So we need to do all those sort of things. And the capillary refill time may help you in assessing tissue, the adequacy of peripheral perfusion, given all these gaps.
This is great. Sheila, I just noticed that it's probably about time for Dr. Subhash Todi and Dr. Suchitra Ranjit to join us. We're waiting also for Craig Cooper-Smith, who's rounding in his ICU, and we're hoping that he'll be able to join us as well. There were a number of questions. Sheila, this one I'd actually ask to you. There were a number of questions about sort of how to assess fluid responsiveness. And, was leg raising adequate? Dr. Devacha mentioned about the tidal, increasing the tidal volume and looking at the pulse pressure. Is there a preferred method? And then maybe Suchitra afterwards could comment on for children whether this pertains.
Right, thank you. So before I respond to that question, I'd like to welcome Dr. Todi. Dr. Todi is the head of the critical care at AMRI Hospital in Kolkata. And we also have Dr. Suchitra Ranjit here. She's the head of the pediatric ICU in Apollo Hospital, Chennai. She's also on the task force of the pediatric SSC guidelines. So welcome both of you. And as Dr. Nadkari said, Dr. Cooper-Smith will be joining us shortly. So coming to fluid responsiveness, this is of course my pet subject. In resource limited settings, it is a challenge because a lot of the monitoring devices and including cardiac output monitoring is a challenge. So tests which use an arterial line, a simple arterial line, which would be invariably present in a patient with septic shock. One of the first few things you do if you have the arterial line, pulse pressure variation could be used. We could use the tidal volume challenge. Echocardiography also is quite available. It's a one-time investment, but at least there aren't disposables that you have to keep purchasing. So that also, if you have invested in a machine, which is of course an initial investment and is expensive, subsequently it can be used to assess fluid responsiveness. There was a question on passive leg raising and how would you do it in an intubated ventilator. Now, this is a very interesting question. Professor Jean-Louis Taboul is not here, but the first rule about passive leg raising is that you move the bed and not the patient. So because he's intubated and sedated doesn't mean he doesn't have to lift his legs. You have to move the bed. So that's very important because you don't want sympathetic stimulation by raising the legs, and then you have tachycardia, an increase in cardiac output, and then you're not sure whether it is because of the tachycardia that there's increase or it's because of genuinely an increase in cardiac output. And as Dr. Devacha rightly said, the test is very simple to perform, but the accurate interpretation needs cardiac output or monitoring. So though passive leg raising is easy to do in a resource limited setting, the accurate interpretation needs cardiac output monitoring. You need an increase of 15% in the cardiac output to call a patient a fluid responder. Of course, the group from France has now looked at other ways of interpreting the results using pulse pressure variation and also using pulse pressure, though not as accurate, may be used as alternatives in resource limited settings.
Dr. Subhash, you had your hand up earlier, I think. Was there a comment you wanted to make on an earlier question? And you might be on mute right now.
That was on the use of corticosteroid. The question which was asked, patient who was not responsive to fluid, a lot of vasopressors. I think, as mentioned, that we should not forget low dose of corticosteroids in those patients as well, as a vasopressor sparing strategy.
Dr. Todi, now that you're
Laura,
here,
did you mention, Laura, did you mention that one of the controversies that might be addressed in the next set of guidelines is fludrocortisone?
Maybe. I think there's new fludrocortisone sort of comes back again, and I think there's more recent evidence that does raise additional uncertainty as to what the role of fludrocortisone may be. For that, previously in the last edition, we had a weak recommendation for hydrocortisone in cases of shock on vasopressors. because of sort of quicker shock resolution rather than a mortality benefit from that. And I'm glad you brought that up, because I was about to throw in the chat asking our attendees to do an informal poll of who uses fludrocortisone for refractory shock. When they're adding hydrocortisone, do people add fludrocortisone as well? So if people would humor me and put in the chat that yes or no, that would be great. Thank you.
Thank you, Laura. Dr. Todi, you're an expert on tropical infections. I want to ask you, tropical infections are not much addressed in the Surviving Sepsis Campaign guidelines. What is the global burden or the impact of tropical infections, in these patients with sepsis globally impact?
Yeah. Thank you, Sheila. As Dr. Laura mentioned, that the recent Lancet study had shown that there is almost a double mortality of global impact of sepsis, and 1 in 5 patients die because of sepsis globally. And half of them are from the resource limited setting, which comes into the tropical country, most of them, like, the Southeast Asia, the South Asia, the Latin America. So there is a very big burden of a global impact of tropical infections. I was going through the tables in that Lancet study. The malaria, typhoid, paratyphoid were 5th and 6th most common incidents of global infection, global sepsis incidents. And even the mortality tables, if you go through, typhoid, paratyphoid, dengue, they're almost in the first 15 to 20 global impact on mortality because of the sheer numbers of the number of people being infected. Though, as Jiggy has mentioned, that the mortality figures are less when we compare just the patients who are admitted to the ICU, but the global impact, given the number of patients who are suffering from these diseases, is very high. So I think that was an eye-opener, that the tropical infection incidence of sepsis and mortality, they are on a very high list in the global mortality figures.
Just to add to that, I just want to ask you, so when you don't have your lab tests available yet, is the diagnosis of these tropical infections, patients with this, any different?
Yeah, if we have a section on tropical fever, they come as an undifferentiated fever, fever without any localizing sign most of the time. And many of the bacterial sepsis is there is to be an itis somewhere, but when there is no itis somewhere, but there is high fever, then the chances of tropical infection in a tropical climate becomes very high. And then we need to have some kind of a syndromic approach. A patient coming with fever with rash, for example, in dengue have a very characteristic rash of maculopapular rash with sparing over the extremities. Then we have eschar of typhus fever. We can have fever with severe watery diarrhea. In tropical countries, we still get a lot of vibrios. And if somebody comes with sepsis and having high fever and watery diarrhea, we need to think of vibrio infection. Similarly, with the bloody diarrhea, we should think of amoebic dysentery. Fever with severe cough, dyspnea, and hemoptysis. If we think of tropical infection, leptospirosis, dengue, typhus, they can present with diffuse alveolar hemorrhage and also ARDS. So I think, for example, acute abdominal pain in somebody with whom we are suspecting a severe tropical infection, a typhoid perforation. We still see typhoid intestinal perforation coming with acute abdomen. So I think a syndromic approach is very, very important. And sometimes when we cannot pinpoint a definite organ being involved and patient coming with high fever in tropical countries, we should think of tropical infections. Over to you.
Sheila, I want to switch a little bit. I'm gonna I see that Craig has joined us, and he's sort of in between patients on rounds. So I'm gonna ask him if he can identify, since the release of the 2021 guidelines, what has been the most sort of controversial or problematic aspect particularly in the resource-rich areas. And then maybe we'll switch for a moment or two and let you tell us how this relates to children and sort of a three-pronged assessment and fluid responsiveness in kids. So Craig, welcome.
Thank you. So of course I have no idea what you guys have been talking about. So I apologize if I am repeating something, but I can tell you my day started with a code and the patient is still alive. So that's what I walked into, is the CPR. So I would say you asked for the most controversial, but I'm going to give two most controversial. And it's actually great that Mitchell and Laura are here because they're way more expert in this than I am. The first has to do with the timing of treatment, the timing of the bundle, the timing of antibiotics. And so not inherently within the guidelines, the bundles and the guidelines aren't exactly the same thing. They come out through different places, but people sort of conflate the two, even though one is for management and one of them is for QI. The big change in the most recent guidelines was the timing of antibiotics. Still saying 1 hour with somebody in septic shock, 1 hour with somebody who you're confident has sepsis, but that you can wait longer, up to 3 hours for somebody that is more undifferentiated while you do more looking. Whether the 3 hour time point is right or 1 hour time point is right, I know I'm going to give Mitchell a chance to talk before I say my second most controversial one, because Mitchell's actually leading a study on this. Is incredibly controversial. And again, since you mentioned I am on rounds this morning, literally not knowing that they knew that I was leaving for a webinar, but they didn't know for what. My emergency medicine resident, we were talking about a septic patient and a medical student asked a question, and the emergency medicine resident said, "Oh, antibiotics within an hour. That's like literally the bane of my existence. I have somebody who I'm sure isn't really infected or they have the flu, and I have to give it." And I'm like, well, fortuitously, I'm talking about that in 47 minutes. So I think that is a huge controversy. I'll have a second one, but again, I want to let Mitchell talk because he's really leading the effort on this.
Well, I don't know yet whether it should be 1 or 3 hours. We just started, we're 1 year into the study, but I will tell you that if I come to an emergency room, I want you to just give me the antibiotics. I think it is completely bullshit, this whole argument about 1 versus 3 hours. I really think that's silly. And so I'm sorry to have that reaction, Craig, but I've been dealing with this question for so many years. And if it's my loved ones, just give the damn antibiotics. I will say that you need to marry this with good antibiotic stewardship. So as soon as you give the first dose, and we all do this on rounds, that's when you ask, okay, do we really think this patient is infected? And if we don't, stop it. But really, honestly, just give the antibiotics. That's my thought.
So Veena, I agree with Mitchell, and I like his zealousness. But you asked me the most controversial thing, and I would say that continues to be the most controversial thing. And Mitchell's statement that I've heard about it for year after year continues to show. And again, like literally this happened on rounds. And the other equally controversial thing is the 30 cc's per kilo. And again, that really comes more from the bundles than from the guidelines. It also comes from the guidelines where it was actually downgraded. This time it was downgraded from a strong recommendation to a weak recommendation, based upon strength of evidence. But every one of us who goes to meetings, no matter where we go to meetings, you'll hear everybody say, but what about my patient with CHF? What about my patient with, an ejection fraction of 10%? What about my patient on dialysis? How do I know it's not 27 cc's per kilo? How do I know it's not 33% cc's per kilo? And of course, the answer is, well, you actually do look at the patient in front of you and you should individualize care while also following, broadly best guidelines. But it continues to be a huge thing where people say, but in this patient, we can't have any guidance whatsoever. And it continues to be incredibly controversial worldwide. And I think that actually makes no difference whether it's in a higher or a lower resource setting. It continues to be a remarkably controversial recommendation that, again, is lowered based on strength of evidence, but is still present. Mitchell,
maybe that's amplified because some of the funding organizations and some of the accreditation organizations like Joint Commission, et cetera, might be using these as parameters in order to rate or reimburse, etc. Dr. Bhatia or Dr. Todi or Sheila, Dr. Mayatra, what are the same two most controversial kind of elements in India?
I agree. And I think the fluid one is more because, you know, the also antibiotics when to start, and that's important. But the fluid one, what I want to say is 30 mils, yes, some people think it's a large volume, but the issue is not only just volume, it's 30 mils over 3 hours. So my question to Laura and also to Michelle Levy will be that why not? You know, 3 hours is a long period of time. So why not give a certain, I mean, if you have concerns about giving 30 mils, why not give a certain volume and see the response and then decide whether you want to give more, because you have 3 hours. So what's your take on that? And what's your take on an individualized approach towards this? Why give 30 mils to all comers? Because that's based on one retrospective study, isn't it? I'd like your thoughts, both your thoughts.
Mitchell, you want to go first? You want me to go first?
No, you go first.
I'll try not to curse. I'm not going to emulate you in that respect. I think it's a great question, Sheila. I think you're absolutely correct. So let me start first that the data that we looked at in support of the 30 mils per kilo is observational data, right? And Vinay mentioned this earlier. We haven't said, nobody's done the trial to say, is 25 better than 32? Is 16 the right place? We don't know, right? What we can say is in several large prospective observational cohorts that patients who got 30 mils per kilo compared to those who did not, it was associated with better outcomes. Causal? Don't know. Or is it a marker for other effective sepsis care, right? That these programs that could do 30 mils per kilo in 3 hours also did other things well, right? And so even when you statistically account for that, the association persisted, but it's an association, not causality. And that was the reason for changing the quality of evidence or not changing the quality of evidence, but downgrading the recommendation on this time. I think it's great. To say, what I'm going to do is approach this patient systematically and revisit the question. I think we already heard multiple times from the previous speakers that fluid responsiveness does and can change over time. And so when you look at it at a moment in time, it's an assessment at a moment in time. And perhaps what we need to do is codify that reassessment and say, what, this isn't a set it and forget it and walk away and come back 12 hours later, but rather get back to the bedside and continue that assessment. There's that one study that was done by Ivor Douglas's group looking at essentially that, right? Just looking at a small volume of fluid in the emergency department and then giving additional small volumes of fluid based on an assessment of fluid responsiveness. I think one of the big criticisms that comes up with that study is merely, is it feasible in a busy clinical emergency department? I don't work in the emergency department, but is it feasible to get back to the bedside again and again and again and continuously assess fluid status? Their patient care ratios are different than what we have in the intensive care unit. In general, we have fewer patients and more staff than in the emergency department. So I think there are real questions about the feasibility of that approach. I will say one important piece about the 30 mils per kilo that I think often gets neglected is that, everybody has their patient anecdote, but when we look at the population-based data, there is not signal of harm associated with it. So whether or not you believe it works, I think is a different question from whether there's data to support that it harms patients. And given the state of our evidence now, there is not data for harm. So I'm going to stop there. I didn't curse, Mitchell. Your turn.
An individualized approach, Michelle Levy.
I wish we're getting closer to an individualized approach. I find that it's easy to do a talk on the importance of individualized approaches, but the truth is right now, we don't have any data that suggests. We're about to start a phase 3 trial that's going to do an enhanced trial for a TREM1 inhibitor. But really, in terms of individualized approaches for either fluid resuscitation or antibiotics, it's more of a fantasy. than reality right now. And that's so unfortunate because clearly there are individual responses to therapy, but we're just not there yet. I will say what Laura, I wouldn't want to reinforce what Laura said. The problem with when you said, Sheila, why not just give a leader and then reassess? The issue is the time we have, busy in the emergency department or in the intensive care unit. We give the leader and then maybe we don't quite get back to, okay, did it work? Do we have to give another leader? And so then the next thing you know, it's 4 hours later. And I am convinced that the longer we wait to resuscitate somebody, the worse they do. And I just don't know what the right amount is.
Yeah, by the way, yeah, thank you. By the way, I love to give fluids. It's not that I don't, but I want to mention that the word drown I used was from your talk when the first iteration of the campaign guideline came, and you spoke in New Delhi. And the one word I remembered from your talk was just drown them. And you know, the message, I mean, of course we don't drown our patients, but that was a message that stuck on. That look, give them fluids and don't give enough. You know, give a lot of fluids to these patients. And I thought that was
Great.
at that point in time. Over to you, Suchitra.
You're on
Yep.
mute, Suchitra.
Thank you, Sheila and Vinay. Thanks very much for inviting me on this illustrious panel. And I must confess, I have more than a little bit of imposter syndrome. So I might be a little nervous at the start, but hopefully I should get better. So yeah, I mean, I think what I'm going to say reflects a lot about what all of you have said before. But I guess with fluids, I work in Chennai in India, but even India is so diverse. I don't think all of India can be said is just one LMIC. Within my city, there are ICUs with fabulous resources or very poor resources. So it's extremely diverse. And we're used to seeing many, tropical infections, bacterial, etc., that don't declare themselves when they come in. So it's a policy. I think most pediatricians are now wearing, I did a survey in India and 80% use just 10 mL per kg for the initial fluid. It's what we teach our trainees is like, if you give fluids, it's like adding salt to water, you can't take it back. So it makes sense to give repeated, slow, lower volume boluses and reassess. We've trained our nurses. We have like targets at the bedside of every patient. So how much urine is expected, what is a trend in heart rate, blood pressure, etc. So it's not all dependent on the clinician to make the next decision. So the low and slow works for us. And the other point I'd like to say is about fluid responsiveness. Certainly the physiology is not different in children. And maybe about a decade ago, we were very talking all the time about fluid responsiveness. But there's nice data showing that children with septic shock have this diseased glycocalyx. And the fluid response is, it's there in 50%, but by the end of 60 minutes, 90% of those fluid responsive patients are no longer fluid responsive. But that initial response kind of, triggers more fluid. The first fluid worked at the end of 1 hour, they're no longer fluid responsive. So the feeling is, why not give more? First fluid worked. So at the end of 12 hours, they are pretty bogged down. And I really would use the word drowning because that's what is happening. And in all of India and in the pediatric community, I think I may have been responsible for it because I'm pretty strident in my talks. We're kind of going for earlier vasoactives. So after 10 or 20 mL per kg, we start earlier vasoactives. We have our own study showing that earlier vasoactives had a very definite fluid sparing approach. And what was most important for the patient, it had an ICU resource sparing approach. So hardly any patients needed ventilation, hardly any patients needed dialysis. So really, I mean, I'm terribly biased because I'm a little anti-fluid compared to all of you in this panel. I believe that maybe we shouldn't be drowning them and then saying, yay, we rescued them. That maybe we can prevent the whole thing in the first place. So we really simplify the entire, the regime, and which is, I just led an international group of pediatric septic shock researchers in writing up an article in Lancet, where the same approaches. So there's no evidence yet, unfortunately, but earlier vasoactives have a fluid sparing and a vasoactive sparing approach.
Right. Thank you so much. I want to ask Dr. Devatia, there's very less on, included in the surviving current iteration on management of sepsis in resource limited settings. Do you think that we need a separate guideline for this, or do you think you need a separate section in the surviving sepsis campaign, the guidelines, or do you think elements for resource limited settings guidance should be incorporated within the various elements? What are your thoughts on that? And then I want to ask Laura, how is this feasible to do in the next iteration? Over to you.
And Sheila, Subhash has his hand up as well. So
Right, of course. Dr. Devatia.
Okay, so if you are, should I go first or? Okay. So, yeah, so let me just wade into the previous question first, very briefly. And, one thing is when you say individualize, it should be individualized to the patient and not to the doctor, right? So we don't want everyone coming and doing their own thing every now and then. So it's nice to have a reasonable number, which is reasonable. And I think now 30 mils per kilo sounds huge, but for let's say 1.5 to 2 liters in an average Indian male, and maybe 1 to 1.5 liters in an average Indian female, then it doesn't sound so bad, right? So I know earlier we used to say, I think before Mitchell Levy started coming to India, we had others who said you got to make them swell to get well, but I think we are well beyond that stage now. But so that's one. And secondly, if you look at all the trials, Classic, Promise, Arise, all got that 1.5 to 2 liters, and they all seem to do well. In the recently published Classic trial, in a subgroup, which you see those who got less than 30 mils per kilo to start with actually had a slightly worse outcome. But that's again a small subgroup, etc., etc. But I think it's reasonable to say, give that 1.5 liter one upfront, and then you start looking at fluid responses. And you can keep on arguing to give 10 plus 10 plus 10 or 15 plus 15. That's my this thing to the controversy. Regarding your question is whether we should have a separate guideline for a resource limited setting, I'd say probably not. For example, the surviving sepsis guidelines are extremely well researched, they're extremely methodologically well done. They've got all the evidence, it's all appraised. There are certain recommendations which may have to be interpreted differently, or some alternatives may have to be found for a resource limited setting. For example, lactate. So if lactate is not available, what would you do? I don't think you can change the recommendation that you should measure lactate if the evidence supports that still, or whether you should target resuscitation to lactate if the evidence still supports that, which is probably a little weak. But if lactate's not available, what would you do? Would you look at base excess? Would you look at something else? That sort of thing. If you can't have invasive blood pressure monitoring, what would you do? And we can. The only problem is you can keep on stretching it. What if you have nothing at all? I mean, I don't think we are really looking at. So if you have 0 and if you have 100, I don't make recommendation the entire spectrum, but we can provide alternatives within the context of the entire guideline.
So you believe that we don't need a separate guideline, we don't need a separate section, it should be incorporated. Laura, as you are aware, we are doing a global Delphi process on the management of sepsis in resource limited settings. So how do you think in the next iteration of Surviving Sepsis Campaign guidelines, we could, incorporate this? And what are the kind of PICO questions we need to be asking going forward?
Yeah, thanks for the question. And I think it's a really difficult question, right? Because the guidelines are a huge effort, right? We're summarizing an enormous volume of literature, some of which doesn't apply to low middle income settings, doesn't certainly, and unfortunately still, although a growing proportion is originating from low and middle income settings, most of the data is still generated in high income settings. And so I think there's a good point of you don't want to lose the methodologic rigor of the guidelines where you're saying we've done a very rigorous systematic look at the literature and we've summarized it. But I do think there's a lot of space for giving guidance on how that might be adapted to different resource settings and recognizing that different resource settings are different, right? We already heard that not every low and middle income setting is the same. Right, that what you have available in a middle income country in Brazil may be very different than what you have available in Zambia, or what you have in New Delhi in one of the private hospitals versus a public hospital. Right, even within the United States, we have different resource settings depending on where you work. So I think there may be space to provide guidance to that. I think Hallie and Massimo's plan to ensure that there's at least 2 panelists representing a low and middle income country setting on each work group will help provide that context. And I'm not speaking in an official guideline capacity now, so Vinay, forgive me. But one of the things that I think about is then sort of, do you need a guideline document that summarizes the literature and says this is these are resource agnostic approaches from the, and then kind of toolkits for adaptation in different resource settings and say, here's permutation A for this resource setting. Here's permutation, you can kind of choose one from each menu type of approach. That's a different, and that's not something that SSC has officially kind of pursued, but it is something we've had conversations about.
Right.
Or as you mentioned, it really is under intense consideration, right? We're trying to raise funds to be able to bring people together to start to address that. But as you say, it hasn't been confirmed, funded, and put in place. And so I think, Sheila, the consensus document that you are putting together, really addressing this, will uncover the gaps and the priorities that type of Surviving Sepsis Campaign group could address.
Thank you. Dr. Todi, you have your hand up. You want to add something?
Just a short comment on the fluid thing. Most of these Western studies are the patients get entry after getting almost 30 cc per kg, and then they are randomized to liberal or restrictive. Even the Clovers trial, they all got 2 liters. I think because of regulatory reasons or ethical reasons, they are not able to conduct that kind of study. But I think like you and Dr. Divati are doing research in India under ISCCM aegis, this might be a place where to truly have a restrictive versus liberal strategy, because most of the Western studies I see are first they all get 30 cc because of various reasons, and then they are randomized. It's not possible there to do these kind of studies. So I think because of the historical, the sort of studies that we have, I think it might be even ethical to have a truly restrictive versus liberal in countries like us. So I think that was the comment I wanted to make.
Thank you for that comment. I want to ask Craig Cooper-Smith a question. There's lots of questions in the chat about albumin. So, about large volumes, how much do you give? When do you start? And we all know we have leaky capillaries, we're giving crystalloids and not, so what are your thoughts on this? And what kind of volumes do you give? And when should we initiate giving albumin?
Yeah, so, and I have 2 minutes before the webinar ends, right? For this 35-minute question. Great. So the guidelines give albumin a weak recommendation based upon relatively poor evidence. So, the biggest studies, if you put them together, none of them show a benefit. When you do a meta-analysis of mortality, The most recent one doesn't show a benefit, but it does have significant fluid sparing effects, and there's some secondary benefits, which is how I got to a weak recommendation. But every time you look, there's like, hints, like the Albios trial was negative, but in the subset of sepsis patients, understanding it's exploratory, or in the SAFE trial, there was a benefit in septic patients. In the Albios trial, there was a benefit in septic shock patients. And then you do the meta-analysis and you put it all together, and there's no benefit. But I think truly we don't know. So what do I do? So what do I do if I'm using a bunch of crystalloid and I work in a surgical ICU and a liver ICU? So there's a lot of times that I'm using a bunch of crystalloid. And ultimately, what's my threshold? I don't have a number. My threshold is when I feel like I'm using enough fluid that I'm going to start hurting oxygenation, but the patient continues to need fluid. That's around the time that I switch to albumin. And that's really based upon data that suggests it really does spare fluid use. It does, have some benefits on oxygenation and stuff, but there's not a clear benefit in outcomes. I'm sure you guys talked in the first hour and a half about how difficult it is for a single strategy like changing the types of fluids to actually show a mortality benefit, because you've talked about precision medicine. So sort of my global take is probably beneficial. What I personally do, and again, I could talk about this for an hour. I'm a little bit chiller than Mitchell Levy, but I have what I call my albumin rant. What I ultimately do is I say, once you've given enough crystalloid that somebody's starting to have troubles with it, I switch to albumin. And I actually think, even though albumin is way more expensive, at least in the United States, I think it is something that we overuse much in the hospital, but underuse in sepsis.
Right.
So Sheila, time is running short. I'm going to ask you if you would just capsulize and summarize, but I'm also going to ask each of the panelists to come up with a word or a quick phrase that in their mind characterizes Surviving Sepsis campaign at the moment. I'm going to sort of choose good and getting better. But Sheila, go ahead and summarize, and then we'll come back to the panelists for a pithy word or two.
Summarize, because you had such a great perspective on different aspects of management of sepsis. Dr. Tori told us about the differences with tropical infections, how to distinguish between bacterial and tropical infections, and the initial management before you get the lab tests. Dr. Tewatia highlighted the importance and the emerging data on the capillary refill time, and also highlighted the limitations on use of capillary refill time. I think Dr. Mish Levy gave us a very nice perspective about justifying why it's reasonable to give 30 mils per kg. It's not so much volume, and it's not practical to keep on reassessing fluid responsiveness. And perhaps that could be a starting point to give that amount of fluids. And I think Suchita gave us a very nice perspective on fluid management in the pediatric patients. And coming to Laura, Laura's told us what's in future, what we could expect. And also, reiterated what Dr. Tewatia said about, having different, within the same guidelines, within the same surviving sepsis guidelines, to have elements for resource limited settings incorporated. And I think that's very positive, knowing that, the plan is to have people from resource limited settings within each of those statements that is made. And excellent overview on albumin from Craig Coopersmith, who of course came in later and gave us his thoughts. But overall, I would say, I think this was a fantastic discussion, and we tried to address at least most of the questions that were, put forward in the chat. So over to you, Vinay, and probably you can.
Yeah, I agree with you. Thanks everybody for participating, participants as well as panelists. Sheila, thanks for having the idea to put this together, bring us closer. Laura, what was your comment for surviving sepsis?
You asked for my pithy saying, so yeah. I said surviving sepsis campaign, sepsis beyond surviving.
There you go. Mitchell, did you have one?
No, not really. No, sorry.
Give them
your comment was bullshit, wasn't it? Isn't that what you said?
I would just say comprehensive.
Comprehensive. Fantastic. What about the others?
Sepsis, choose wisely. Sepsis, choose wisely.
Choose wisely.
Okay. Should you try?
Yeah, if you can't do fluid responsiveness tests, at least use fluid tolerance as an endpoint. because it would
Okay.
mean that it's unsafe to give fluids, even if they are supposedly fluid responsive.
Maybe good advice around the world right now is be tolerant, huh?
Yeah.
Yeah.
Craig Cooper-Smith.
Craig?
Yeah. Craig Cooper-Smith.
Tolerance also, fluid tolerance also means fluid intolerance, right? So that
Yeah.
So the right balance, individualize, perhaps.
Right.
Craig Cooper-Smith, the last word from you.
Let's just stole mine, Sheila. So my pithy saying is life-saving, but also individualized to the patient in front of you.
Right. All right. I think it's been excellent. We could just go on and on talking forever. There's so much to discuss and so many questions still coming in the chat. But in the interest of time, we'll wind up. It's a late night in India. It was just starting your day in the United States and other parts of the world. So thank you very much. And thank you. Special thanks to Vinay Nadkarni for facilitating this and putting this forward. And I said, we have to do something together and let's start. And this was really the first plan going forward by the two presidents. So thank you to all the delegates and thank you to all the faculty for being here and for your time and for this excellent discussion. It has been a great learning for all of us. Thank you very much.
Thank you.
Thank you. Bye-bye.
thank you and bye-bye.
Bye.